Just to give you a quick overview of what we'll be discussing today, we'll be discussing a little bit about the healing community study, so giving a little bit of background there. We'll discuss the HCS communications campaigns and the strategic approaches they took. We'll also hear from some of the sites that participated in the healing community study around their strategies and lessons learned and best practices. We'll also share some resources, and then we'll have some Q&A at the end of the session. So now I'm very excited to introduce our amazing set of panelists. We have Dr. Verdana Chandler, who is recently retired from the National Institute on Drug Abuse, NIDA. Prior to her retirement, Dr. Chandler was the director of the Healing Community Study and the director of the AIDS Research Program. We also have Jennifer Reynolds, who is a senior manager of health communications marketing promotion program at Oak Ridge Associated Universities. We also have Kara Stevens, the senior health communication specialist project director at Oak Ridge Associate Universities. We have Dr. Nikki Lewis, who is currently the associate professor of communication science at Indiana University. She was also the former faculty lead of the communications work group for the Kentucky Healing Communities study. And then lastly, we have Emma Rogers, who is the assistant program director of the National Center for Engagement and Diabetes Research at NYU Langone Health. And she was the former director of community engagement for the Healing Community Study in New York at Columbia University. So to dive into our current content, we'll first hear from Dr. Chandler. I'll kick it to you.
Thank you very much, Braden, and thanks to all of you for attending today and spending a little bit of time with us. We're going to showcase one part of the Healing Community Study intervention, which are the communications campaigns, and I'm going to provide a little bit of a broad overview of the study, as well as the different components of the intervention, so that you can understand a little bit more about how the communications campaigns fit. So the Healing Community Study began in April of 2019, and it was jointly funded by NIDA and SAMHSA. It included 67 different communities in 4 states, and the total population of individuals living in those communities and that were impacted by the communications campaign and other parts of the intervention were 10 million individuals. The goal was to reduce opioid-related overdose fatalities, but we had really important secondary outcomes as well that included increasing naloxone distribution, increasing access and utilization of medication for opioid use disorder, or MOUD, and decreasing high-risk opioid prescribing. Next slide. So this just provides you with some of the baseline characteristics of the community, so you can have a little bit of an understanding of those communities that were enrolled and participated in the study across the different states and overall, including the total population. The opioid overdose death rate per 100,000 at baseline was extraordinarily high, overall at 33.4, with a range of 40.6 to 27.5. We knew that it was really important to include both rural and urban communities because solutions in one area may not necessarily be transferable to another because of infrastructure and because of cultural and climate differences. So we ensured that there was a nice representation of both rural and urban communities in the study. And it just happened that at that particular time, all of the states were Medicaid expansion states. Next slide. So I'm going to spend just a second talking about the design of this study. It was a multi-site, parallel arm, cluster randomized waitlist controlled trial, which is a mouthful. That just basically means that half the communities were randomly selected to receive the intervention, while half of the communities just continued doing the things that they were already doing. And then after the intervention period, there was a time where outcomes were compared between those that were in the intervention and those that were not in the intervention. And you can see there a timeline of when we started up the study, of the intervention time versus usual care, the comparison period, the sustainment, and then study closeout, analysis, and dissemination of results. And the study now has wrapped up, and we're just finishing up a few final papers. Next slide. So the Communities That Heal intervention had 3 components to it: a community engagement, which included diverse coalitions that came together to develop a response strategy using a data-driven approach to be able to address the opioid epidemic within their community. The Opioid Reduction Continuum of Care approach, or ORCA, which was a menu of evidence-based strategies that were known to be effective in addressing opioid use disorder, as well as reducing overdose fatalities. And then community-based health communications campaigns that you're going to hear more about, that were intended to accomplish several goals that I'll talk about briefly, and then others will go into in more depth. Next slide. So within the coalitions, 2 states initially built on existing coalitions, and that was Kentucky and Ohio, where 2 states developed new coalitions for the study, New York and Massachusetts. The coalitions worked through a phased approach to examine data, select EBPs, identify partner organizations that they would work with for implementing those EBPs, and then monitor progress, and they were supported by communications campaigns. Next slide. And these are the phases of engagement for the coalitions. I'm not going to go through each of those. We've done actually a previous webinar with Addiction Policy Forum, where you can find more information about these different stages and about what happened and what communities did during the stages of the intervention, and how they got to developing and implementing an action plan, and then what they did to help plan for sustainability of the interventions that they implemented as a result of the study. Next slide. The ORCA, as I said, is a menu of evidence-based practices. It included 3 primary areas, which focused on distributing naloxone to prevent overdose fatalities to high-risk populations and also high-risk venues, to effectively deliver medication for opioid use disorder, and then to also promote safer prescribing and dispensing of prescription opioids. And ORCA was implemented within 3 settings, a minimum of 3 settings, and many communities expanded to others that included health and public health settings, criminal legal system, and behavioral health settings. Next slide. And then a snapshot of a little bit of the data related to the evidence-based practices. Communities across the study adopted over 1,000 different strategies, which I think really demonstrates the utility of the coalition's staged approach, as well as of the toolkit from the ORCA that was built. You can see at the bottom the number between the intervention and the control communities for naloxone, as well as MOUD and safer prescribing and dispensing. The majority of the strategies focused on naloxone, but there were also a lot of strategies on MOUD and safer prescribing. Next slide. And then finally, what you all are here to learn more about are the health communications campaigns. And I'm especially proud of those campaigns and this team that worked so diligently. The communications campaigns really helped us to not only engage our communities, but also to work toward changing hearts and minds. The goal was to really increase the adoption of evidence-based practices while also decreasing stigma. We had priority audience groups that included providers, community leaders, and people with lived experience. And then broadly, the topics included naloxone, MOUD, and then staying on MOUD. And there were over 6,000 different materials and ads that were produced as a part of this campaign. And you'll get to see samples of those. And what you see here are some of those materials. You see pictures of individuals, and the pictures of the individuals that you see here on the campaigns, many of them are community members themselves that volunteered to have their faces be a part of the campaigns. We also developed materials in a variety of languages to match the needs of the communities, and tried to make sure that we had diverse faces of individuals included. Next slide. So next, I'm going to turn it over to Jennifer Reynolds, and she's going to provide an overview of the communications campaigns.
Righty. Brayden, I don't know if my video is showing up yet. And can you hear me?
Yeah, we can hear you.
Okay, great. I'll go ahead and get started then. First of all, thank you all so much for being here. It is an absolute joy to be able to share some of this with you and to see so much interest in this important topic. When HCS was first conceptualized, only one research site included communication campaigns in their proposal to be a part of the study. And as communication became the third pillar of the intervention, there was a lot of skepticism among researchers, among community members, among funders about was it important to involve communications in such a rigorous clinical trial? And as Ardana alluded to, as time went on, I think everyone began to see the value of communications for many reasons, some of them surprising, and I'll get to that a little bit later. But I want to start us off with one of my favorite communication quotes. It's not the best product that wins, but the best known one that wins. And this is so true. Marketers have known this forever. And I think it's pertinent to our topic here. You know, the solutions or our products for HCS, naloxone, MOUD, these are not new concepts. You know, these solutions have been around for a while. The intervention is not that they don't exist, but rather that people don't know about them or that they cannot access the interventions because they are either not readily available in the community. So our communications task becomes about improving awareness, driving demand, increasing buy-in such that communities want to adopt these interventions and they're invested in making them accessible to those that need them. And it's also important to recognize for the HCS, like I'm sure many of you in your communities, these communities had been dealing with addiction for decades. So they had deeply ingrained attitudes, beliefs, and stigmas that ran counter to EBP expansion in these communities. So it really was about laying a foundation and creating a social environment that made it easier for impacted individuals and loved ones to ask for, receive, and maintain the support that they needed and deserved. So it really was a foundation. And it was the first part of the intervention that was released. And it really did work to engage coalitions, communities, and even our own research teams around our common goal. And so I want to provide you a bit more of an overview of our HCS communication campaigns before I turn it over to my colleague Kara to talk more about the planning process. Next slide, please. Alrighty, so I think it's really important to recognize that the HEAL campaigns were evidence-based, meaning that they were grounded in health communication theory and based on scientifically proven principles for communications and marketing. And some of those key principles I want to share with you now. The first was to have behavior change as an explicit goal or objective. It is great to improve knowledge and awareness, but at the end of the day, what can we focus on and measure? And that's behavior change. How many people are accessing naloxone? How many people are accessing MOUD treatment? Next, we want to use formative research in the design and planning of our campaigns. And we want to focus on homogeneous population groups. We have a famous saying in health communications, if you are speaking to everyone, you're speaking to no one. Everyone is not a target audience, folks. So what I really charge you to do is look at narrowing your audience, particularly when you have a low budget like we did for the HEAL campaign. So our average paid media spend per campaign per community was under $5,000. So this was not a giant multi-million-dollar effort here at all. So when you're thinking about targeting your campaigns, think about your audience. Who is most at risk? Where do they live? Where do they work? Where do they worship? What do they believe? All of these are important questions to ask when you're defining your audience. communicate directly with your audience, not just through intermediaries, we recognize that particularly if your target audience includes individuals in active use, this can be challenging, but we were able to identify innovative ways to communicate directly with that audience. The next three are related. Multiple executions, meaning multiple iterations or forms of your messages. High frequency of exposure, hit people again, and again across multiple channels, social media, billboards, print, news. The science says that it can take between 7, some papers say up to 26 times for someone to read, hear, or receive a message before they change their intentions to change their behavior. So it is essential for you to continue to push your messaging. And that really goes to the last point I want to leave you with. This is a sustained activity. You must be intentional and you must be committed to communications. This is not about just recycling the same messages over and over. You have to be committed to do this long term and to evolve as the field evolves. You know, during HCS, we had fentanyl, xylazine coming on. The science changed, the drugs changed, and we had to evolve with those. Next stage. So a little bit more about the campaign development process. We used a 3-phase development process: prepare, plan, and implement. And you can learn a lot more about the details of this process in the paper that is listed at the bottom of the screen. But essentially, in the prepare step, we were conducting that research to understand the social environment where we were going to implement the campaigns. So what was happening in these communities? What campaigns had already been done? What had worked? What had not worked? What were those knowledge, attitudes, and beliefs and behaviors that we needed to account for when we designed our message? And also, what was the media environment? Who was going to be a friend and who was going to be a foe as we worked on sort of expanding access to EVPs? In the plan step, we were really focused on creating those messages and materials and then testing those and revising them to make sure that we chose messages that were most effective at changing behavior. And then finally, in implementing, we were implementing the campaign and then monitoring and evaluating. It's important to know that for HCS, we began the prepare and plan steps at the research site level. And that was because the campaign was the first of the evidence-based practices to go out the door for HCS. And a lot of times that early planning happened before coalitions became involved. So coalitions really got involved more in the plan and implementation step. And this allowed us to start with sort of a common standardized campaign platform that communities were then given to make their own and tailor. And it really was the communities that drove any success that we had for these campaigns. Next slide. So what were communities given to implement these campaigns? So first, it's important to know that each community for each campaign was given a web page with a unique URL that included information about the campaign topic, whether that was OAND, MOUD, stigma, a map that showed all of the locations where someone could access that intervention. They were also given 2 different types of toolkits: a broad dissemination toolkit that included social media copy, graphics, templates for newspaper articles, partner outreach emails. Some included radio PSAs, and partner toolkits, which were very similar to the dissemination, but tailored to the interests, knowledge, needs of specific audiences, be those treatment centers, primary care providers, recovery community organizations. And lastly, each community was given a toolbox, which was simply a folder where we housed all of their campaign materials that had been customized for that community so that anyone that the coalition wanted to share them with had that access. Next slide. So I want to focus on community engagement really quick because I think that is so essential to HCS and to communications. So campaigns were implemented through collaboration with work groups and communication champions. So who were these champions? The sort of the process for onboarding and who these people were varied by state. But sort of the common thread was that these were compensated community experts who were essential to offering insight and access to target audiences for the campaigns. And I think the compensation piece is really important to highlight here because it spoke to that commitment piece, right? So often communications is a sidebar or an afterthought or a volunteer activity. But by compensating these individuals, we helped make sure that we had dedicated experts who were committed to seeing these campaigns through. And they really had a critical role in reviewing their data and making the campaign work best in their communities. And one thing I want to say about the communication champions, we learned that this person does not have to be a communications expert. What we valued much more, we learned, was time, enthusiasm, and connection. So in Kentucky, for example, one of our very best communication champions was a retired court judge who was a grandfather. So through his grandkids, he had access to schools. Through his previous job, he had access to everyone in the court system. He was very active in his faith community, and he was committed to the campaign and the education, and he was just a phenomenal partner in this work. Next slide. And Radonna covered this a bit. I just want to give you a snapshot of what the campaigns looked like in wave 1 and wave 2 of the intervention. So in wave 1, because we had a lengthier implementation phase, we were able to do campaigns on naloxone, MOUD stigma. MOUD stigma was the focus of the campaign, but obviously you can't talk about medications for opioid use disorder without establishing that OUD is a medical condition. Awareness of MOUD treatment retention, and then campaign 5 was community choice. This meant that communities could choose to re-implement a previous campaign with a previous audience that they may not have reached previously. At this time, fentanyl was becoming a huge problem across our communities. And so many of our communities chose to implement a expanded naloxone and fentanyl campaign as their 5th final campaign. In wave 2, we only did 3: naloxone fentanyl education, MOUD anti-stigma and awareness, and community choice. And as Radonna explained, our priority audience groups are listed there. Remember, these are refined by the communities into much more specific and targetable groups. And then our objectives are also listed there as well. Next slide. In the interest of time, I'm going to go through these really quickly. These are just some additional sort of images of what we did with this campaign. This is our naloxone campaign. Our primary messaging was really about anyone can be a responder, be there to save a life in the event of an overdose. And you can see we had multiple implementations or disseminations of this, everything from a palm card to a billboard to a coffee sleeve to advertising outside of a stadium. Next slide. And this is excerpts from our fentanyl campaign. You can see we expanded some of the educational pieces to identifying signs of an overdose. What is fentanyl? That it can contaminate other drugs. It only requires a very small dose to overdose, and certainly the answer is to carry naloxone. Next slide. Some images from our MOUD campaign. Again, multiple different ways to disseminate these messages, from Instagram carousel ads to posters to coffee sleeves to bus advertising. Next slide. And this is some excerpts of our spokespersons for our Stay in Medication Treatment campaign. This was a first of its kind campaign addressing continuation of MOUD. So many individuals think that they need to stop using MOUD too soon. And that was really the focus, to stay in it as long as you need. And we filmed this in the middle of COVID via Zoom and had the most incredible group of spokespersons participate. Next slide. Okay.
Great. Thank you so much, Jennifer. So hi, everyone. My name is Kara Stevens, and I'm going to be talking more about the approach to campaign planning that we leverage to help communities with the campaign dissemination process. Next slide. So a little bit about ORU. So we did support all 4 of the research sites during this study, and we provided participating communities with campaign planning and implementation, multimedia design, media buying, capacity training and technical assistance, as well as campaign evaluation and reporting support. Next slide. And while providing this support, we did receive feedback from participating communities that requested assistance with the campaign dissemination planning process. So as Jennifer mentioned, we did have a varying level of degree of experience and expertise across our coalitions, as well as our communications champions. So they wanted a little bit more assistance and help with the actual campaign dissemination planning process. So to address this need, I developed an integrated marketing and communications planning guide, which accompanied an in-depth training webinar. And this resource was intended to help the communications champion lead their communications work group through the steps necessary to successfully plan, implement, and evaluate the HCS campaigns. But it definitely can be adopted by other communities to plan for any other different campaign topics. And so I'll go into more detail of each step in the next few slides. Next slide. And the first step is to ensure everyone on the communications work group has a solid understanding of the campaign platform. So a campaign platform includes the goal, which is a long-term outcome statement that helps establish the overall tone of the campaign. It also includes the single overarching communication objectives, or the change among the priority audience groups that we aim to achieve with the campaign, as well as the priority audience groups we aim to reach with the campaign materials and messaging, as well as the key messages and calls to actions that were developed for each audience group. And I do want to note that the campaign platforms that were developed for HCS, while they were rigorously reviewed by a committee and based on the data and science available to us at that time, as Jennifer and Radonna mentioned, these are several years old now. So we've developed some evergreen resources that we will share at the end of our presentation today, but just a note, with the implementation of any pre-existing campaign, you just want to make sure that you review the messaging as well as the priority audiences that were intended to be reached, and make updates based on your community needs and your available data. Next slide. So next, we look at the available data that helps us identify the terms of sociodemographics as well as overdose characteristics in the community. And this would be the same for other campaign topics. If you're implementing this process for a different campaign, you will just be looking at different data sources. So within the IMC planning guide that we developed, there are worksheets within that guide that allowed communities to document this information and just keep track of it. And that is pictured here on the right-hand side of this slide. Next slide. And the next step is segmentation and audience analysis. Both Radonna and Jennifer mentioned this in their presentation. So this is really critical. So it's that first subset is really, getting an idea of who are the intended audience groups for the campaign, have a solid understanding of who those are. And then so for the HCS campaigns, as Jennifer mentioned, these are people with living experience or people who use drugs, depending on the HCS campaign. the key influencers, so people like loved ones, family members, faith-based leaders, sorry, recovery specialists, as well as healthcare providers. Or if you're creating a new campaign, this might entail, other priority audience groups that you're intending on reaching. Next slide. And then based on the data that you've collected and what you know about your community and your market area, you then want to narrow the campaign priority audience group into audience segments. So if you're not familiar with audience segments, this is just a way to create a smaller subset of that larger audience group with things in common that helps you customize your core materials. And this helps you personalize the messaging, the language used, any imagery involved in your campaign materials and ads, so it resonates with them more. And this substep also helps you identify the best communication channels to use to reach them. And you can segment audience groups by socio-demographics, so things like age, gender, occupation, geography, so where they live or where they work, perhaps near hot zones or near local clinics and recovery centers, and behaviors. So what are they doing on the internet? What do they search for online? What are those keywords that you could possibly use in paid media strategies? And then psychographics. So how do they think? How do they feel? Next slide. Next slide, please. Okay. And so again, the IMC planning guide provides a worksheet for this information. And so after having a discussion with the communications work group, you can document the audience segments and prioritize reaching during the intervention. And the next sub-step is identify those audience segments. So is identifying the communication barriers and channels. So what are the ways this audience segment prefers to receive information? So are there any communication barriers or preferences that you need to consider when identifying dissemination tactics to reach this audience segment? And also consider the communication channels that are available to you, not just own channels, that your organization might not own, but also partner organizations. So what existing communication channels can they provide with established reach and leverage into the priority audience groups that you're trying to reach? And again, there's a worksheet for this as well in the IMC planning guide. Next slide. And then once you've identified who you need to reach and how you are going to reach them, you're ready to start drafting a community-tailored campaign plan. So to help communities with this process, we did develop a campaign dissemination plan and tracking template. And this was just an Excel spreadsheet that had all of the headers there that are pictured on the right-hand side of this slide. And it started with things like the intended audience group for that campaign, the segment that they've identified that they're going to prioritize reaching, and then it gets more granular into the dissemination tactic that they plan on implementing, as well as the channel or location and possibly a partner that they might leverage to disseminate that campaign material. Next slide. And then for the New York's research site specifically, we did SMART dissemination objectives, and this was just to help ensure that our communities were implementing dissemination tactics across owned, earned, and paid media. And this is just a screenshot of what that looked like. Next slide. And this is because within health communication and social marketing, as Jennifer mentioned, there is a standard called the dissemination trifecta. And this trifecta just reinforces the implementation of multimedia dissemination strategies across owned, earned, and paid media channels to help you reach those audiences where they live, work, play, and worship. And it also helps ensure repeated message exposure. And so next slide. As we mentioned previously, so this repeated dissemination is important because it just means on average, what we call the rule of 7. So this is at a minimum. So as Jennifer mentioned, this could be up to 27 times, but at a minimum, we know that an individual must see a repeated message at least 7 times before they will take a desired action. So repeating dissemination across numerous mediums will not only help increase your reach, but also increases the probability that they've repeatedly noticed the messaging and all of the information noise present today, that they remember that information, and ultimately it resonated with them enough to inspire them to take the desired action. Next slide. And within the template in New York, we created a separate tab for the pre-planning steps and had communities populate the tab with all of the worksheet information, like the audience segments that they prioritize reaching based on their data and community-specific needs. And we also included a separate tab for each of the smart dissemination objectives, where they tracked all of the associated dissemination tactics that they planned on implementing, the materials that they needed to implement that tactic, as well as when they planned on disseminating this specific campaign material. And I will just say, I do recommend establishing your dissemination objectives before campaign implementation, just to help level set what it is you and your team or your work group hope to accomplish during campaign dissemination. Next slide. And so this is just a screenshot of the campaign dissemination plan and tracker template that we developed. Next slide. And then for the HCS campaigns, ORU developed over 6,000 tailored campaign materials to support communities with the implementation of the dissemination tactics that they identified in their plans. And customization was informed by the communities and really specifically by the completed campaign dissemination plans. And this customization included the use of different images, such as local spokespersons, or changing out stock imagery to make sure that it resonated with the audience segments that they were prioritized reaching, as well as including local landmarks behind images of individuals, just to make sure that it resonated with individuals in their community. We also ensured that the content reflected the community needs as far as the medications that were available in their community. We also included things like spokesperson testimonials and quotes. And as far as products, so customization included developing all sorts of different types of materials based on the format or the channel that they were leveraging to disseminate that campaign messaging. So lots of different types of materials, as well as meeting any of the design requirements, such as size, duration, resolution, things like that. And then finally, we also customized the materials to include the community-specific information. So their community HCS website, vanity URL, we included things like local hotline numbers, logos of any partners that were helping disseminate campaign materials, and things like that. Next slide. So as you can see on the left-hand side of this slide, you can see the core campaign graphic, and then the examples on the right-hand side that we use to tailor the actual imagery used. So the first one being spokespersons featured, and then the second one being that we included a landmark that was a really well-known bridge in the community, just to make sure that it resonated with the intended audience segments. Next slide. And then this is an example of the different content, so including the tailored testimonials and quotes in the customized graphics. Next slide. And then just a few examples of all of the different types of products that were created based on, the core graphics. So it started with the social media graphic that was provided in the toolkit, and we developed things like billboards, magnets and clings, palm cards, posters, video content. So lots of different products created. Next slide. And then this just shows the local, community specific information that was, tailored to that specific community, such as partner logos. We included things like local spokespersons and their vanity URL as well. Next slide. And I will say, with an eye on sustainability, so we wanted to make sure that when we left the end of the study, that our communities were able to pick up, these campaigns or develop new campaigns and move forward with creating campaign materials in the future. So we did develop a capacity training and spokesperson video guide that helped communities recruit and feature their own local spokespersons in their materials. And the guide just included recruitment and recording guidance. It included things like interview prompts, taglines, and PSA scripts that they could edit as needed, as well as some templates in Canva that they were able to edit and use on their own. So within New York alone, we had communities featured 22 local spokespersons in their materials, which was pretty outstanding. It's just a testament to how amazing our communities were. Next slide. And then additionally, probably one of the most important steps is making sure that we are, not just implementing, but also monitoring progress. So we did encourage communities to track their progress, at least on a weekly basis, within the campaign dissemination plan and tracker. And you'll see that, the screenshot on the right-hand side, there were evaluation columns, and it included both quantitative, so key performance metrics for based on the channel that they selected, as well as qualitative questions pertaining to anything that they did to improve or might need to improve in the future. And with that, I will turn it over to Emma.
Thanks so much, Kara, and thanks everyone for having me today. Hello from New York. Today I'm presenting on behalf of our team, which included Kara, who I'm so fortunate to worked with on the Healing Communities study. Next slide. So today I'm going to be talking about one of our Wave 2 communities, Rochester, which is located in Monroe County in New York. Next slide. However, before I do that, I just wanted to give a quick snapshot of just the work that was happening in New York. Radana and Jen and Kara all gave a lot of detail about this, but just again to reiterate, in New York, our community-based coalitions were led by county government. This included departments of public health, mental hygiene, and social services. So that was something that was unique in New York. And then similar to the other states that participated in the study, we were very data-driven. Everything had to be data-driven decision-making, which some of our communities were used to, but others were not. And so there was a big learning curve. And also in terms of the data that was accessible, really varied by community. The third thing is community at our heart. Working with communities, doing community engagement was everything. So all planning was community-led or informed by our coalitions, which included multi-sectoral groups, community-based organizations, community residents, government agencies, healthcare providers, et cetera. So it was a really diverse group of people helping to make these community-informed and led decisions. And finally, again, champions were vital to the work that we did, especially on communications. Jennifer talked about this earlier, but some of our champions had a lot of communications experience. Others did not, but were extremely enthusiastic. And all of these champions were phenomenal in different ways. Next slide. So again, I'm giving today a case study for Rochester, which is in Monroe County. This is a map of our Wave 1 and Wave 2 communities. Rochester is located to the west in New York State. It is a city, not as big as New York City, with only 100,000 people, but it is urban. And in terms of overdoses at the time of the study, this is 2023, there were 96 overdoses and 16 of them were fatal. Next slide. This slide outlines the coalition and the communications work group in Rochester. As Radana mentioned, in New York, our counties created separate coalitions for this study. However, in Rochester and Monroe County, there was a long history of this work focused on opioids and coalition work. And so for Healing Communities study, the Rochester team and the government agency we worked with was led by the impact team at the Department of Public Health. And again, this was a very diverse group of individuals and organizations that were helping to lead this. Within the coalition, there was a communications work group that had 5 members, so not too big, but very mighty, with 7, who represented 7 different organizations. There was one communications champion. He was phenomenal, and you'll hear from him later. He actually worked for the Monroe County Department of Public Health and the impact team, and this was extremely useful for the work because at times, as I think many of us know, it's very hard to work within the government. And so it was great to have him on the inside doing that. The work group met weekly, sometimes more, to do this work, and technical assistance was again provided by myself and Kara and others. Next slide. So today I'm going to highlight Rochester's work specifically in Campaign 3, which was staying in MLUD or medications for opioid use disorder treatment. Again, here are the campaign objectives and audience groups. I know this was shared earlier, but this was a really important campaign for our communities, and it focused again on people staying in treatment. What were the barriers? How could it be most helpful to them? And the audience groups, again, were people with opioid use disorder as well as their needed supporters. And we let our communities decide how to define that, and each community varied. Next slide. So again, data-driven decision-making, vital to everything we do, including communications. And so this slide talks about sort of how Rochester utilized our local data to make those decisions. So in Rochester, what was really phenomenal was that they actually created a data dashboard. This was actually in the works before the study started. It is really a model of community-based dashboards across New York and really across the country. What was so important to this is that it's accessible to the public. So anyone could access this data. It was extremely timely. It was more timely than the New York State data that we had that we could share. And so again, every day they got updated information. They updated this to their dashboard, and this data was utilized in informing the planning of the campaign. So again, this includes everything from overdose data by race, ethnicity, by age, by sex. It also had a heat map, which was phenomenal, so that again, they could think about where to focus all of the campaign materials. So again, it was extremely useful and just a great example of collecting data and utilizing it. Next slide. So the Rochester work group, communications work group, used that data to prioritize their audience segments. And so for people with opioid use disorder, they focus on African American males who are 50 years of age and older, low literacy and first generation. There's a very large Hispanic Spanish speaking population, so they did a lot of work there. And finally, high risk populations and sex workers, individuals engaged in transactional sex. And then finally, in terms of needed supporters, again, broadly, families of people with opioid use disorder, as well as supportive staff at partner organizations and agencies. Next slide. Here's a quick snapshot of our dissemination tactics. As Kara showed earlier, we had an amazing spreadsheet that she created, this template, which a lot of thought went into in terms of determining, again, based off data, based on what the community wanted and needed to reach their priority audience segment groups, what types of owned media, what types of earned media and paid media would be best to reach those groups. And so again, it runs the gamut, but I just wanted to highlight a couple of things. For owned media, social media, as one can imagine, was very important. They utilized the county health department's social media pages and their partners' pages. For earned media, again, it was fantastic that the Commissioner of Public Health was very supportive and did press releases and held press conferences, so that was wonderful. They also did a lot of radio PSAs, which was interesting. I think people feel like radio is sometimes no longer relevant, but it is extremely relevant, as Rochester demonstrated. And finally, paid media. In New York, we had a centralized media buyer and planner who we connected with our community-based coalitions to come up with a plan to reach the audience groups. And so again, that included social media ads, outdoor, so billboards, and then I'll note gas stations, which actually was piloted in our first wave of communities and very popular amongst our communities in wave 2. Next slide. Here are examples of materials, many of which you saw earlier. But again, it was just phenomenal to see the different types of materials and how they tailor them specifically to the populations that they were trying to reach. And again, you'll see examples from gas station ads to convenience store ads, social media. This team did a lot of on-the-ground outreach, and so you saw a lot of palm cards or postcards being distributed, but again, all specifically tailored to this community. And actually, in the earned media, I forgot to mention, they did ads at the airport. which is really exciting. So again, our team saw those. It was really wonderful to see and plastered all throughout the airport. Next slide. Now I'm going to show a quick video from our communications champion, Alex Benitez. Again, he was so enthusiastic and phenomenal and really led this work. And so he's going to describe some of the dissemination that the coalition and work group conducted. Fortunately, we can't hear the sound right now.
So I'll try to do that again. Sorry.
Okay, no worries.
Did you hear that?
It's just a little snippet of some of the things that we were able to do. Over here, we have our team at one of our forums we were able to implement or incorporate our campaign into the different initiatives we started within the study. So one of the big things was our family forums, and this is where we were able to get out a lot of our campaign stuff, right? So we were able to collaborate with Andrew, who runs the family forum on our side. We had other organizations come out. This was actually pretty funky. Alfredo, he works for one of the community organizations, so he would literally be on roller skates giving out a lot of these palm cards, a lot of the information, especially in these hot zones. Our impact cards back here as well. Right here in this bottom right-hand corner, that was our drug take-back day. So our outreach team, along with other organizations, were able to take some of our campaign material and give it out.
Thank you. Appreciate that. Next slide. And finally, I'll just leave you with a couple of lessons learned from campaign planning from the New York team. Number one, again, securing leadership buy-in always is important in any aspect of this work. For Rochester, it was especially important having the support of their leadership at the county public health department. So without that, we would not have been able to do as much as we could. Again, the communications champion is vital. Alex was phenomenal, and we were so lucky to have him, and as well as the other champions across the state. Again, data. Can't emphasize enough. This was something that, again, some of our coalitions and work groups were hesitant around, but became such champions and advocates for this, and it informed every aspect of their planning, and they've taken that forward with them. In terms of dissemination tactics, I just want to emphasize that I think people, tend to go toward paid media tactics, but unpaid can be not just as effective and often even more effective. So you don't need a lot of money to do these campaigns, although it is nice to have. But again, there's just a lot you can do with little money if necessary. Spokespeople, we talked about this before, but again, if you have people who are from your community, these messages will go a lot further, be much more effective, and there's buy-in, again, from the participants and people in the coalition and the community. And finally, again, thinking about local media outlets, establishing relationships with the radio stations and the TV stations, podcasters, et cetera, before you launch the campaign is very important, because when you actually want to do the campaign, they'll be very supportive, provide a lot of unearned media, so without money, and be real champions for this work. So with that, again, just want to say thank you to everyone, especially Kara and our team at Columbia, and I will turn it over to Nikki.
Thanks, Emma. So I'm going to be presenting a case study for Knox County in Kentucky. Braden, you can go ahead and just skip through the next couple of slides. So here we go. Okay, so just to set the stage here, Knox County is a rural Appalachian county in southeastern Kentucky, and it's a rural community of about 30,000 residents in the whole county. The county seat is Barberville, so kind of where the courthouse and everything is only about 3,000 individuals. So just a different kind of perspective here looking at this community. The employers there are healthcare, retail, education, and it's one of the few coal producing counties in Kentucky that has continued to sustain its population over time. It was also included as part of Wave 2, which allowed us to employ lessons that we had learned in our Wave 1 communities into Knox County. Next slide. The lessons that we did bring into Knox County and our other Wave 2 communities were, as has been mentioned before and just now by Emma, is introducing kind of the value of communications early on, and the importance of communication champions being your advocates in these communities. And again, finding individuals who have a strong interest and investment in the topic and in the issue over actual skills, because we can teach people up, right? You can teach people to learn specific skills. And of course, the importance of tailored campaign materials. You'll see there on the right there of the power of local voices. As part of our evaluation, we found that ads featuring local spokespeople performed 57% better on average than ads featuring stock photography. Although we don't understand the mechanism of how necessarily they perform better, as far as were people able to detect stock images over local images, the data bore that out, that if we used, even if the photos weren't as good of quality as the stock imagery, they had more impact and more visibility and acknowledgement in the communities. And of course, overcoming some of the digital and social media challenges with kind of placing different types of materials and ads, and then the importance of establishing groundwork with local media and partners from the get-go. Next slide. So just to consider, kind of going all the way back to Radana's segment earliest on in the webinar about understanding culture and climate in each of the communities that you're working for. We had established coalitions in our communities, and so we wanted to leverage the local Knox County Coalition insights in addition to some of the insights we gained from Wave 1. Some relevant local data that was very much top of mind as we developed the campaigns was understanding that overdoses had been increasing in Knox County over 2020 and 2021 as we had started working in that community. The drug-related deaths were impacting a large, wide range of ages, so not just necessarily younger individuals using recreational drugs, but a wide swath of individuals across Knox County. Most of the overdoses were happening in individuals' own homes, followed by hospitals, hotels, and others' homes. And then the community overall was made up of 60% men and 40% women, 77% of households with a computer, which is under the national average of somewhere between 90 and 95%, and 92% living in the same house as a year ago. So what this kind of tells you is not only the types of materials that might be the most effective in Knox County, but the places where they might be most effective, right? So if people are staying in their same home, if they are, basically kind of in this space where overdoses are happening in that space, what can we do to create messaging to place them in those spaces where they're most likely to see them? Next slide. Knowledge, attitudes, and beliefs. A lot of our rural counties in southeastern Kentucky, there's an overarching kind of Appalachian mindset to be aware of. So there's a larger historical context to think about here. Basically, that they are a very self-reliant culture, that they are less likely to seek help from other individuals. They have a strong suspicion of large corporations and the federal government based on the coal mining and other types of industries. And so this is kind of the overarching mindset. But in Knox County in particular, there was a high level of apathy and otherism, kind of a third person, it won't happen to me. There was a hesitancy around naloxone in general, with the belief that it encourages people to use drugs as a safety net. And most people did not even consider having naloxone at home, even if family members or themselves used drugs in some way, shape, or form. And there was pushback in the communities of faith, schools, and local government, some stigma and beliefs related to, a hesitancy to engage with some of the HCF evidence-based practices. So those were some of the challenges that we were dealing with. Next slide. So what we did to try to overcome some of these challenges and what we found to be really effective in campaign planning was identifying some really amazing dedicated champions in our communities. And it's important to first acknowledge that these individuals take on a huge amount of risk in order to put themselves out there in their communities. That being said, to your left, you see Kay Powers. She was a member of the school board and lost 2 children to overdose in the time that we worked with Kay. And then you see Jake Knuckles, Knuckles to the right, who was the local police chief and also the coalition chair. They were brave enough to share their stories with us and participate in our video campaigns related to carrying naloxone. And in a community of 3,000 people in Barberville and a very small county population overall, you can imagine that in these rural communities, these are very visible and recognizable individuals. These are people you're going to see at the grocery store, that you're going to see in town. And so it's important to understand that these individuals took a risk, and for this particular community, it was met with a huge amount of acceptance and appreciation and love. Next slide. These are just, I know this is way small, I can share this later with you, but these are all positive comments to the video that Kay Powers posted, showing support and sympathy for her loss and her appreciation to put herself out there. We can talk at a later webinar about managing negative comments, but with Kay in particular, this was a super successful kind of story related to her sharing what her challenges and what she had gone through. Next slide. Another example of our dedicated champions was in our campaign 2 with MOUD. Who you see here is Megan, who is a local recovery coach. And although the original billboard we had designed with Megan in mind was going to just show her by herself, she really wanted to include her husband and her children on the billboard image to show how much MOUD treatment and recovery had impacted her life and how important it was for her to include this as part of the message. So we worked really hard with our team to get approval so that we can include her whole family. And again, just a testament of our dedicated champions in our community. Next slide. And then finally for campaign 3, because of some of the groundswell we saw with Jake and Kay and Megan, we went all in on local influencers. And so we had 21 community members in Knox County for campaign 3 alone when we visited naloxone fentanyl to make a personal statement that they carry naloxone because it saves lives. And there was a wide swath of participants across the board who put themselves out there across all of these different domains that you see listed here. And so this is just a testament to the commitment of Knox County. And we'll walk through here just a couple examples. If you go to the next slide, remember the barriers that we faced with education and faith-based communities. We had Sherry and Jeremy, representatives from the faith-based community and the school community, putting themselves out there, acknowledging the importance of naloxone and saving lives. Next slide. And then, of course, we had some of our law enforcement and criminal legal individuals sharing the same message, as well as our prevention specialists. And then in the middle there is actually Kay's granddaughter, Jenna, who actually kind of recorded a TikTok style video demonstrating the importance of naloxone and how much she wished she had naloxone when her mother passed away. Next slide. We had multiple paid media dissemination strategies trying to meet those barriers, and we put that advertising in spaces where we knew overdoses were high and drug use was high. For the sake of time, we'll kind of move through these. Next slide. We had, of course, palm cards, tear off flyers, posters, and we've seen a lot of materials to this point, so we can go to the next slide. And I want to mention here in specific that although vinyl banners are smaller, vinyl banners in particular in Knox County worked really well at $250 a piece because they were moved around the area and the communities, such as at the police station, the courthouse, and the town entrance to basically get more traction, more bang for your buck, if you will, as opposed to purchasing a billboard. And so that was super effective there, as well as we had a press release that was published in the local newspaper and on the website of Union College in Knox County. We also had a video circulated in a larger swath of the faith-based community through the Ministers Association newsletter. Next slide. Finally, some lessons learned and takeaways. The value of localizing campaigns, using local images. People can tell when it's stock versus local, and so that was super important for us. Using grassroots to establish community engagement from the get-go, and not just doing sharing and tagging, but really building relationships with our influencers and our representatives in those communities and businesses to continue that relationship. Next slide. And finally, there is some training on print and social media with your communication champions, but that is not the priority. And also too, because you have individuals in your community putting themselves out there, planning supporting events or mini campaigns around your dedicated influencers really can support their stories and show your buy-in and your dedication to their participation. And the time between campaigns can continue to allow for momentum building, strategy enhancement, and flexibility to better serve the community.